Lymphoma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Lymphoma Hub podcast. Today we'll be hearing from Grzegorz Nowakowski from Mayo Clinic, Rochester, US, and Laurie Sehn of the University of British Columbia in Vancouver, Canada.
Hello, so I'm Laurie Sehn from Vancouver, British Columbia, and I'm here today with my esteemed colleague, Dr. Grzegorz Nowakowski from the Mayo Clinic, and we're going to be talking a little bit about a debate that we had at the ICML meeting, which revolved around what the optimal upfront therapy is for diffuse large B-cell lymphoma. So for those of you that treat lymphoma, you know that it remains a big challenge because we've got a standard of care, which is R-CHOP, which most of us use in our own clinics, that has a good chance of curing patients, but we know that not all patients are cured. And unfortunately, those patients that aren't cured with R-CHOP actually still fare relatively poorly, and treating relapse refractory disease is a big problem. So optimizing upfront therapy remains really an important research question. So the point of argument I had was that R-CHOP remains the current standard of care. In my own clinic, when I see patients with DLBCL, we do FISH testing to identify patients who are double or triple hit in terms of dual rearrangement of MYC and BCL2 and or BCL6. And those patients I do currently treat differently. So we know that they've been pulled out in a separate category at WHO, and many of us are intensifying therapy. In my own clinic, I use dose-adjusted EPOCH-R. But for all the other patients, particularly the bigger category of DLBCL NOS, I continue to use R-CHOP as it is still the best curative treatment that we have available with a, most favorable toxicity profile. And it still continues to be my standard of care. But how about you, Greg? How do you treat your patients?
Thank you, Laurie. So I will start from disclosure that Dr. Sehn won this debate by wide margin, and I must agree with it. R-CHOP is the standard for a majority of patients with diffuse large B-cell lymphoma. But during this argument, I was trying to make an argument that this is a standard, not necessarily the standard, because there are some patients which may benefit from other therapies. And you already mentioned the first category, which are patients with a double hit lymphoma. Even with DLBCL histology, there appear to be a benefit to more dose escalated therapy in this setting. It's a little bit unclear which one is the best of those. Dose-adjusted EPOCH-R, as you already mentioned, is frequently used in this setting. We tend to use CODOX-M or other Burkitt-like regimens in younger patients, younger than 60, and dose-adjusted EPOCH-R over 60. So that's one category. The other category of patients is this molecular category of ABC, diffuse large B-cell lymphoma, which is historically associated with worse outcome. Number of trials there and mixed results. Unfortunately, none of them of the randomized phase 3 studies really moved the bar there. And so R-CHOP is the standard, although because the results are inferior, we consider it somewhat insufficient standard, and clearly there is an opportunity for improvement in this patient category. Finally, we have a number of patients who are not eligible for R-CHOP due to age, performance status, or sometimes organ dysfunction. We call them sometimes left behind because they're left behind in our clinical trials. And that's a new and emerging group, which is now more and more focus of ongoing research, how we can actually develop new therapies for those patients, not necessarily incorporating R-CHOP to move the bar in this group of patients. We know from databases that those patients don't do as well with R-CHOP, and they frequently require dose reductions, which then results in a inferior outcome. So R-CHOP is the standard, but probably not the only standard, because we have those patients which may benefit from alternative approach here.
Yeah, well, I have to say I would fully agree with you. But if we do think about that group of patients that is suitable for R-CHOP, so they've got DLBCL NOS and they are of an age and comorbid status that they be appropriate for R-CHOP, I think, it's been disheartening that we've had a series of clinical trials really that have failed to move the bar in terms of standard of care. It's clearly, we've seen a series initially of chemotherapy-driven trials with intensified chemotherapy that, really failed to make a difference. And then more recently, we've had some of the novel therapies added into the R-CHOP background, and pretty much universally, those trials have been negative. I think, one of the trials that I participated in was the Phoenix trial, looked at adding in ibrutinib, so the BTK inhibitor, to patients with non-GCB DLBCL. So of course, this takes us into the realm of now biomarker-driven trials, where when we've got targeted agents, they may not be appropriate for all patients anymore. So we're going to have to identify and select for patients based on who's most likely to benefit. From that particular trial, I think we did learn some lessons, and that was that when we do biomarker-driven trials, there is the risk that the delay in doing the centralized biomarker can eliminate patients who need immediate treatment. So we saw that probably the outcomes were much higher across the board than we would have anticipated, because we weren't able to capture the highest risk patients. And in the end, unfortunately, that trial was negative overall. But intriguingly, when they did a subgroup analysis, there was positive benefit for younger patients, but not seen in older patients, thought possibly because the toxicity was prohibitive in older patients. They couldn't get the R-CHOP, but there was a definite signal of PFS and OS. So that trial is going on to be repeated now with acalabrutinib. It's already ongoing. I think it's a valid question worth asking. But until then, until we validate that, of course, it's not something that I would advocate for in clinical practice. But you are directly involved with two very important trials that looked at the inclusion of lenalidomide into R-CHOP, and I'd be interested in your take on the results from those trials and whether or not they should translate right now into a change in how people treat their patients.
Yes, and those two trials were robust, which was the global phase 3 study for patients with ABC subtype of diffuse large B-cell lymphoma, evaluating addition of lenalidomide to R-CHOP21 versus R-CHOP alone. And the other study was E1412, which was a US intergroup study. It was a phase 2 study, again, looking at the addition of lenalidomide to R-CHOP versus R-CHOP alone. Those studies have very different design. E1412 was open to all the patients, and the global study, robust, was based on a real-time gene expression profiling with nanostring platform to identify patients with ABC subtype of diffuse large B-cell lymphoma. When we designed those studies, we thought that approach used in robust was the smartest thing we could do, because we're already selecting patients which are higher risk, at the highest risk of progression after initial therapy, and the most likely to benefit from addition of lenalidomide based on the previous preclinical studies. But we found out exactly what you mentioned, that using this real-time biomarker result in a hesitancy of the investigators to put some of the high-risk patients on this study. They were worried that if patients not going to get treated for a week or two, required to get the biomarker back, this is going to affect the patient outcome, and selected probably unconsciously to some degree patients which were lower risk. And we put huge effort in trying to make this biomarker real time. So the turnaround time in the lab was only 2.4 days. So this was done as efficiently with global effort as you could imagine. But life is life, and in reality, you still have to collect the slides and make sure that it's being shipped, and all the logistics still resulted in very long so-called time from diagnosis to treatment in this study. Median was about 31 days, but there were quite a few patients who had it actually for several months before they initiated therapy. This is in contrast to E1412, where anybody who just had a lymphoma was immediately eligible for this treatment. And this trial, in contrast to robust, actually did show a signal that that the addition of lenalidomide could be beneficial in this setting. Unfortunately, this was a signal-seeking study, phase 2, so it's not practice-changing, particularly since robust study was negative. Now, this work is still moving forward because ours were CHOP. Now, exactly with the dose and schedule used in E1412 is moving forward in another global study called the frontline, where tafasitamab rituximab, a novel anti-CD19 antibody, is added on the top of R-squared-CHOP. And this doublet added on to R-CHOP is then compared against R-CHOP alone. There was a small feasibility study called FirstMind, which showed that this approach is feasible, does not result in a dose delays of R-CHOP. This was presented at ICML. And there was also a presentation in Trials in Progress where the design of this new global study was presented as well. And in designing this study, we used the elements of what we call the modern design. So we're trying to remove all the possible barriers from putting patients on a trial rapidly, allowing pretreatment steroids, and capturing those high-risk patients, which you alluded to, because it's so important for the outcomes of those trials. And sometimes there is this urgency in treating physicians to start treatment urgently and without considering the trials. But in our experience, as you alluded already to, those are the patients who have the most to gain from being on the trials. So I would really encourage everybody to consider those or other trials ongoing in this space and capturing those high-risk patients in those trials. And you can do it through stabilization of pretreatment, which is now quite well established.
Yes, I think it's exciting to see that despite the challenges we've had so far, that there are numerous ongoing trials, I think, that show a lot of promise. Probably the first one out there that we'll be hearing about, of course, is the POLARIX trial, which was an attempt to introduce polatuzumab vedotin into the frontline setting. So polatuzumab vedotin is an antibody drug conjugate targeting CD79B. And of course, we had randomized phase 2 trial in the relapsed refractory setting where it was combined with bendamustine and rituximab that showed an improvement in PFS and overall survival, and now it's approved in that setting. But the POLARIX trial actually moved it forward in untreated patients, really replacing it out for vincristine. Now that trial, I think we'll have to see, but it's anticipated that we may get results in the next several months, and we'll have to see whether or not that's going to finally move the needle on outcome. If that trial is positive, what do you think will happen to the other ongoing trials right now? I mean, will they have to adjust and accommodate? Will the answers that they yield, if they stay with a similar design, have meaning? How are we going to integrate the results from different trials?
So that's a great question, because what do you do with the control arm? Will you need to adjust it? I think this will depend on the magnitude of benefit in the study and potentially some subgroup analysis as well. How consistent was this benefit if the POLARIX is indeed positive? Because some of those trials are targeting different patient populations, like younger patients or really high-risk patients, and are the same benefits seen in the same patient population. POLARIX study will be very important to know how to move forward. Because you're absolutely right. If POLARIX is significantly positive across different subgroups, then R-CHOP as a control arm could become a substandard in ongoing trials.
I think the world's going to get a lot more confusing. So, although we could agree to disagree right now about what the standard of care is, I think that we can probably agree that, with the exception of the subgroups of patients that you mentioned at the beginning, R-CHOP is still the standard, but to move that bar forward, it's exciting to see that we do have different options, and there are a series of trials, as you say, adding on to R-CHOP. We still have the possibility of other trial designs, such as looking at maintenance therapy after R-CHOP, although I think that we've not yet seen that work with a variety of agents and may not be the best way to move forward. I think one of the exciting approaches is this concept of response-adapted trials. PET scanning was used as a response-adaptive trial design just recently presented at ASH, where they tried to move CAR T-cell therapy forward in the upfront setting. And I thought that was really a proof of concept trial, but we can't really say much about whether or not that's going to be an appropriate approach. I think circulating tumor DNA, remains a really exciting potential predictive marker for allowing us to develop response adaptive trials. And then, of course, probably the holy grail would be to ultimately get rid of chemotherapy altogether and replace R-CHOP with some of the exciting novel agents that we're seeing coming forward. But, with that, I think there's still a lot of work to be done, and it is an exciting time, and I think we all need to watch the literature very carefully.
I think we definitely agree that this is probably the most exciting time in diffuse large B-cell lymphoma, with all the new agents coming and how we can combine it. And sometimes when we talk about the frontline therapy, because we had so many negative trials, there's this aura of negativity that the previous trials were not necessarily successful, but they led to something. I think we've learned a lot. We've learned a lot how to focus our effort on the patients who really can make a difference with those new treatments. I'm really optimistic that this new generation of modern trials will move the bar.
And that's something we can agree on. Okay, well, it's certainly been a pleasure talking through this today, and I think we look forward to all the data that's yet to come.
Thank you. It's actually a pleasure talking with you.
Thank you for listening to the Lymphoma Hub podcast. We would also like to thank our supporters, Bristol Myers Squibb, Genentech, Insight, Roche, and Novartis.
Lymphoma Hub podcasts, brought to you by Scientific Education Support.